Hello, everyone. Good morning, good afternoon, good evening, wherever you're joining us in the world today. And welcome to another episode of the Realist Lens for researchers who keep it real. Today, we're diving into one of the most complex and high stakes areas of healthcare medication management in older people and dementia care. It involves navigating frailty, risk, behavior, and the realities of care systems that span families, pharmacists, doctors, nurses, and beyond. The solutions aren't simple, and the interventions aren't one size fits all. That's why realist evaluation and synthesis have become such a powerful tool, helping us ask not just what works, but for whom, in what context, and why. In this episode, we'll be exploring how realist evaluation and synthesis have been used to understand complex real world interventions and what these evaluations reveal about medication safety and optimization in older people. Whether you're a realist researcher, a clinician, a policymaker, or just realist curious, this conversation promises rich insights into both method and meaning. So stay with us and let's explore how realist approaches can illuminate the messy, meaningful world of dementia care in older people and medication management. And we've got a very special guest to talk about all this, who's gone from pharmacist and practice and senior positions and all sorts that he will be able to explain much better than I will. And this is, of course, Ian Maidment. Ian, hello, good morning. How are you?
Fine, thanks. How's yourself, Alex?
Yes, I'm really good as well. Thank you very much. But I'm really excited to have this conversation on this topic. I know how much work you've done on this and as well discovering the realist approach over the last few years as well to help you answer some of these questions. So I'm looking forward to dive into that. But just before we do that, Ian, would you be happy to just explain a little bit about yourself and your background and your journey into realist to get started?
Okay, so I'm a pharmacist, as you said, Alex. So I spent 20 plus years in practice as a pharmacist in the NHS, community pharmacy. A lot of my time was in secondary care, mental health and dementia care, and older people. I was chief pharmacist, did a lot of research, a master's in health services research, and that was mainly qualitative. And that gave me the knowledge of research methods. I then moved to academia in 2012, pulled together my work and did a PhD by previous publication. Um, that was focused on dementia. Um, and really, that was focused on medication error in dementia. And I guess the key conclusion was that people with dementia are at greater risk of medication error um, because you haven't got that barrier. So, if, for example, yourself or me were given a blue tablet when we usually expect a pink tablet, we would say to the doctor, "Why has the color changed?" But obviously, if you've got cognitive impairment or if you're confused due to dementia, you may not be aware of that. Often there's a family carer involved, but they're doing so much themselves may not pick up themselves. That was kind of the theory behind my thesis. It was essentially looking at pulling together some other papers that I'd done. So I moved to academia as a senior lecturer, building on my experience. I then started to get some grants. Um, and one of the first grants that I got was looking at the role of community pharmacy in supporting older people with dementia with their medication. It's only a very small project funded by Pharmacy Research UK, just a year. So we did some interviews and we did a literature review. And then, kind of halfway through the literature review, my research associate said to me, Ian, I think we should change this from metasynthesis to a realist review. I'd never heard of realist research before that. And then so I looked into it and I realized you can't just change it halfway through with 6 months left. It's too complex. But I thought this is a really interesting approach. Okay. This is a really interesting approach. So after that, building on the work from the Pharmacy Research UK grant, we did quite a big study, which we'll talk about later, memorable, which was older people, including those with dementia, what helps to optimize medication management using a Realist approach. That's NIHR funded. That was my first Realist project. Um, since then, I've led a number of Realist projects, mainly funded by the NIHR. Had a little bit of UKRI funding, looking at COVID vaccination, mainly focused on older people, people with dementia, and also severe mental illness. And I've been involved in lots of supervision as well. Um, I've successfully been promoted. So I joined as a senior lecturer. I'm now a chair as well, professor. And I was recently given an NIHR Senior Investigator Award. So I've kind of worked on realism and used it to really understand what's happening and why. And I think the reason why I was so attracted to it was it helps you to think, why is this really happening? What's happening that makes this not work the way we think it will or expect it will? And it can really delve underneath the problem. And certainly, I think that's what it's done on the projects which we completed.
That is fantastic because you're bringing that experience, not only the practical one that you're mentioning as well from years work in the NHS, but also for a few years now, leading on realist projects, getting funding for realist projects. And as well, just I think one of the reasons that many people get into realist, which is understanding that depth and those causal pathways that may be happening to understand complexity, which in your case, of course, is older people, medication management, and dementia care, which is very layered and very complex. So I guess building up on that, because I'm interested to hear about your work. You mentioned around a realist synthesis, a realist review that you've done. I know you've done quite a few, and we'll speak around some of the projects a little bit later on. But within your work specifically, how has realist synthesis helped you uncover what works and why in medication management for people living with dementia? What has been some of the key mechanisms or key explanations that you found in your work, and how has the realist approach helped you get there?
So I think the realist approach has helped me to delve and understand what's really happening. Okay, so it's really particularly the interviews. So if you're doing realist research, particularly in areas where there's little research, I think the interviews really help to illuminate it. So I think looking at memorable, I think some of the key mechanisms were the role of family carers, how they support and how they need support, and how that they need regular support. How for a family carer, working with someone with supporting someone with dementia, it's almost like a job. It changes the relationship often between the spouse, husband and wife, because they're responsible for the medication. So they find it a real burden and they find it a lack of support. So I think probably the key thing from Memorable was this burden and how they need support with the burden and how that burden's hidden as well.
That is really interesting, and I always love hearing some of the different findings that realist work brings and bringing it to life, really, because I think it every time a realist study is done, it just gives us and sheds a little bit more light into this unknown, into this. There's a really nice metaphor used by Justin Jagosh, where you're in this dark forest and you have this little light, this little lamp, and that synthesis of evaluation just gives you a little bit of light within that, and then you're going to keep getting the pieces of light eventually as you go through that. So that's really nice. And you mentioned something as well just earlier about the power of the interviews and the power of the realist interview, which of course is different from a more standard qualitative interview. And for those listening, I'd recommend listening to the episode with Anna Manzano around realist interviews to give you a little bit more details on that. But I guess that there has been, particularly in your background from qualitative, some key methodological lessons, because going from a qualitative, meta synthesis, meta narrative to then a realist approach, there must have been some key lessons methodologically that you've gone through time. So what have those been for you when conducting realist evaluations in mental health and pharmacy settings?
I think the two approaches are linked, if I'm honest. So I think it's like a Venn diagram, and you've got realist research and you've got qualitative methods. I know realist is seen as methods neutral, but obviously, if you're interviewing someone, you're going to get words back. So I think there's overlap between the two, and I think sometimes people overcomplicate it. I think probably some of the tensions have been is if you're doing a interview study after the literature review, if the literature review doesn't give you enough to evaluate on the interview study, then you're kind of not in the dark, but you're kind of more exploratory approach, if that makes sense. So I think that's one of the tensions you've got. Okay. I think as I said, they are different, but they are related. I think the key thing is to come back to what you found in the literature and use that as your basis, but also to look for other threads, look for new things as well. Because if you're just too rigid, um, you're restricted on what you find, particularly if the literature's limited. So I think it's. I mean, I've never led a realist project in such as I've been the person actually doing the legwork. I've supervised them, so I've never had that experience. But my experience as a supervisor is that they're linked and they're overlapping a pure qualitative approach and a pure realist approach. And with all these methods, we need to be flexible. What you're trying to do is you're trying to understand what's happening and why it's happening. And I think if I go back to my original qualitative work, although it wasn't realist, okay, I think I did use that realist type lens. So you're trying to interpret what you find, looking for these hidden things. So that would probably be my advice.
That's great advice. Thanks, Ian. And I completely agree that there are some similarities. I guess that one of the key differences is that theory testing and refinement and confirming when you're having that teacher learner cycle and
Yeah.
I'll show you mine if you show me your situation, which becomes quite interesting. But one of the key things that you mentioned there is when the literature is limited as well, and that sometimes can be a struggle and a challenge. Have you found that in your own projects where you've had struggles with the limited literature that then you've had to adapt anything, or how has that impacted on your realist work?
So often the literature is limited. Probably I can give you a recent example about this where we're looking at prescribing by pharmacists. And there's very little written about independent prescribing by pharmacists. This is integrate NIHR funded. So I think what we can learn from is prescribing by other professions. So if nurses prescribe, how does implications from the research in nurses, how can that affect pharmacy as an example? That's one thing we could do. The research is ongoing, so I can't say exactly what we're gonna do, but you're looking for similarities and commonality in the literature. But the challenge then is you also need to keep it focused and not look at everything. That there's this tension there between getting a good understanding, but not making it overwhelming. And I think trying to navigate that's quite a challenge.
Well, it's both a science and an art in a way, Ian. Making sure that you do something that is focused enough for the question, but also that you are trying to uncover those mechanisms, which, as you mentioned, and actually it's also part of some of the more realist guidance, that it is good practice to also, if there is limited literature, to look at similar contexts where these mechanisms could be
Yeah.
firing.
I
And that
mean,
is interesting.
the other thing we've done quite a lot of is to use stakeholder engagement. So both all the projects I've used a practitioner group with expert clinicians and social care, and also I've used particularly lived experience people with the illness. It's critical on a realist review where you're not going to do interviews to test your findings, to test your theory. So you can then take your findings from the literature to the groups and say, "This is what we found in the literature. How does it resonate with you?" I think the tension is that there's a real tension there, particularly if the literature is limited. You're saying we can't say anything because the literature is not saying anything. So it's using the groups appropriately so that they can actually confirm what you're finding, and then you can then use that for justification to do future research using more an interview-based study.
I love that, Ian, because that again shows, I think, one of the key areas of the realist approach, probably in comparison, as you mentioned, with qualitative, that with the realist approach, that stakeholder PPI group, a lot of the time, it's not going to be just it's not going to just guide you into some decision making. It's actually going to contribute directly to that theory development, testing, refining, and confirming. So in a way, it really much becomes co-produced, those findings, and many times.
Yeah, so I would say the findings have been co-produced, all of them. Um, I mean, uh, if you look at the recent project in SMI, severe mental illness, we've had, because they're the most recent research that I've done, they really have been co-produced. I mean, Mediate, which was medicine optimization in severe mental illness, was just a review. So we really had to engage the stakeholders, both clinical and practitioner, and I think that's really critical, particularly I would say for a PhD where you may not have content expertise. So I think because I've worked in this area for 20 years, I've got that clinical experience, that practice experience. If you're a PhD student coming into the area and you've got limited experience, then you need to get people who've got experience to support you. because they can really help to ground your research on the real world. And
Mm.
so I'd say to any PhD student who's got a PhD, a stipended PhD, if they haven't got clinical experience or haven't got relevant experience, get good stakeholder and practitioner groups. But I'd also say to them, think about how your experience could be relevant as well, because lots of us have got lived experience, even though we may not realize we've got it. So, for example, I've got lived experience caring with elderly relatives, which has helped to inform my research. So in a way, I've got clinical expertise and also I've got um, real world lived experience from a patient public engagement perspective.
Well, yeah, absolutely, and we usually leave the top tips by the end, but already giving some lovely Easter eggs to our listeners, which absolutely I completely agree with what you're saying there. I think that you have to be very specific and proposive with how you're choosing your stakeholders, as you mentioned, and looking in your intervention or your phenomena or whatever you're studying. What are some of these key actors? Paulson and Tilly mentioned, say, in their book in 1997, to not only focus into one specific actor who is receiving the intervention, but all the other stakeholders are going to be involved. So the people designing, delivering, and obviously, of course, since then, there's been also much more published research on stakeholder engagement in realist evaluation and synthesis, which is fascinating. But also, this also leads nicely into the complexity of your work, because we've mentioned around why you have chosen realist work, in the complexity of understanding medication management for older people in dementia care. Some of the key methodological lessons that you mentioned surrounding, the, as you say, the Venn diagram between qualitative and realist, but also particularly in recent years, some of the advancements with some more quantitative methods as well, like realist economic evaluation or realist surveys, which are also really interesting to find out. But I guess that the summary of everything that you've mentioned so far is that it is very complex. It is very complex to deal with people with SMI, severe mental illness, with their carers. It is a vulnerable population with policymakers, decision makers, gatekeepers. There's so much going on. I guess that's what I'm trying to say. So I guess that in this complexity, and you bring your 20 years of clinical experience as well, but I guess that we, as we know, the clinical world and the research world can absolutely complement each other, but there'll be some differences there. So how do you navigate the complexity of evaluating those interventions from a realist lens that involve multi-agency, multidisciplinary collaboration?
I think that's difficult to give a simple answer in a short interview, to be honest with you. So, how do you navigate complexity? I think there's a tension between giving this really complex report, which is valid in the academic language, and also giving a one-page summary, which is what policymakers and practitioners and clinicians want. So you've got to um, ground your research in the real world and try to get a message across, which I think is relevant for people in day-to-day practice. And the memorable study, the NIHR study, we had to produce a word report for that for the funders. And I had to try to distill that in a key message for practitioners, which I managed to do. So that's got a key message in one sentence. So if people forget anything else about the study, this is one key message. And so I'm going around doing lots of presentations to practitioners, to patients on this key message. So I agree with you, there's a real complexity and it's difficult to navigate. I think it's trying to acknowledge the complexity but at the same time remain focused. So don't let the complexity overwhelm you. Kind of welcome it, welcome the messiness. Expect it's going to be complex. Expect you're going to feel like you're walking through treacle at times. To live with it, but at the same time, particularly on these funded grants and also for PhDs, you've got to deliver to time and target. So you've got to work back from the finish date and think, okay, I've gone through the complexity. This is as far as I can get within that time scale. I've got to finish going through the complexity and kind of wrap it up. But then the key thing I would say then is when you do the write up, say, this is what we could do within the constraints of the grant. This is what people need to do next.
That is really interesting, Ian, and I'd love to hear more around your process into, dealing with that complexity and dealing with, for example, going from a 3-year research project to one sentence, because That is again an art and a science. And yes, the realist approach embraces complexity, absolutely, and welcomes it as part of the messy social world that we live in. But at the same time, in Paulson's most recent book, he talks about stopping rules or about drawing a line in the sand at some point, as you mentioned, and the need of being both pragmatic in your world. Because technically speaking, we could be developing and refining theories all day, every day until forever, right? So I guess that's a follow-up question from that, because I'm sure that listeners will be interested in it. What has been your own personal process from dealing from complexity to a one sentence? What has been the process to get there?
Okay. So I can talk probably best about memorable. So I think the I've never thought of this before, so I'm kind of giving you trying to actually articulate my cognitive processes, okay? I guess with memorable, we got the final report, and then I kind of thought, what is the key messages or the key messages here? What do I think really resonates? And then I went back to my clinical practice, and I kind of felt what really adds on to what didn't I know? Because I worked in this area a long time, which I know now from memorable. And how can I articulate that so that when I present it to a busy GP, busy pharmacist, they will understand it. So I tried to look at what the report had done, look at the key messages from the report, relate that to what I knew before, and from that distill a key message. And the key message was it was think medication burden. So, and just to give it a bit of context behind that, so when a doctor or pharmacist prescribes a drug, they think about side effects, but you also need to think about burden. So, can the patient cope with the medication regime? Can they take it? Okay. So, what I say to people is think side effect, think burden. So, when you think about side effects, think about burden. And I think I was surprised by memorable, this real burden on older people with dementia and family carers. This burden's hidden, they struggle with it, and they need more support. So that was the kind of the key messages really.
Fascinating, Ian. Thank you so much. And for anyone listening that is in the field, hopefully they also take that as a something to think about, because I think it's really important, particularly for people living with severe mental illness or indeed older people living with dementia. And I think that you come into a very key area of realist research here, realist evaluation, realist synthesis, because of course we want to embrace this complexity in the social world. But then we go into policy and practice, as you say, the busy GP, the busy pharmacist, the decision maker, that a lot of the time what they want is, does this work, yes or no? And they just want a binary answer. But the realist approach and the slogan, it depends, and it's going to depend on the different contextual features and the actors and on so many different things. I guess that in your realist work, you can mention maybe some of the work of Memorable or Periscope. How has the realist approach informed your recommendations from policy and practice? So you mentioned the process that you've gone there, which is really useful. But how do we make this refined program theories, which again are complex, and there's going to be
Yeah.
different arrows going everywhere, and there's going to be all of this sort of visuals from a realist perspective? How do we keep that into a useful piece for policy and practice?
It's challenging. It's not easy, as you say. So I think it's bearing in mind you've got two almost conflicting areas. You've got this complexity and realism, but people don't want to know about that. They want to know about the simple, the message, the key things that's relevant for them. So I think probably we would partly what I did with Memorable, where I looked at it myself, but also we would get from the stakeholder groups and also the co-applicants as well. So we would get the findings from the literature and the interviews, and then we would still them into policy recommendations. So I think it's working with the content expertise of the practitioner group supporting the research, the service user group supporting the research, and the co-applicants, and then as chief investigator, kind of distilling it into a key message. So the burden message from Memorable, that came out after the project had finished. So that was kind of when I was presenting it, I was trying to think, how can I, in a 20-minute presentation to 50 GPs and pharmacists, how can I get across the findings from Memorable, which are relevant for them? They're not concerned about we found 1,000 papers. What a CMO is. They're not concerned about that. They're concerned about how does this affect their day-to-day practice. So that came out after the project finished, where I was reviewing my findings and thinking, how can I make this meaningful for GPs and pharmacists in the real world? Because this is applied research. Okay. I know you've got a theoretical basis behind it, but we really want to try to make it relevant for people living in the real world, give them some insight for it. So that's what I try to do.
I think it's a very justified thing to do. And actually, I think one of the key messages that you mentioned there is know your audience. So if you have GPs in front of you and busy pharmacists, then what are going to be the key messages? Because it will be slightly different to if you had 50 realist academics that want to learn all about the methodology, then it's going to be slightly different to
Yeah.
someone else, right?
Yeah, so I'm not sure I would be so confident speaking to 50 expert realist academics because they'd be more challenging than 50 GPs. So obviously you're right, you've got to tailor the message, okay, definitely. Because I've got this strong clinical background, then you could tailor the message. So yeah, no, I agree. You've got to tailor it. You definitely got to tailor it. And then if you're also you also tailor it to different practitioner groups as well. So obviously, one of the actors, or I would call them practitioner groups in all these research projects, are social care. Social care, social workers, occupational therapists. So if you're presenting it to them, how's it relevant for them? There's such a neglected group in research. Healthcare research is okay, never enough funding, but it's relatively well funded. Okay, social care research is completely unfunded. And medication management optimization within these populations and probably many other populations, there's both, it's the interface between social care and healthcare. So we really need to work with social care practitioners. And for Resolve, we were quite fortunate. We got some funding from the NIHR looking at barriers for social care practitioners to engage in research using a realist evaluation approach. So it's so key that we involve all these key actors. So I would say to people doing a PhD, looking at healthcare, think about how you can engage with social care. Is there social care relevant? Also think about the charities as well, the charitable sector.
That is so interesting, Ian, and I love that already. Giving another tip to students and to practitioners, which is engaging in social work. And I completely agree. One of the key things, I guess, that in any realist project is having super clear the program architecture, i.e., what are the different components of that program, of that intervention, of that process. And then from there, really link what all the actors are
Yeah.
involved. So, as you say, there will be some actors who are social workers, or not many in that sense. Why is it that they're receiving less funding than others? And to embrace that complexity, then they all should be considered. And linked to that, and you have been working now on Realist for a few years now, and as you say, leading some of these projects and taking the direction, trying to distill that complexity. So I guess that there is a lot of potential as well moving forward for the realist approach in the field that you work in. And I guess that one of the exciting things about Realist is that there's a lot of space for innovation. There's a lot of space to continue developing some of these ideas. I mean, it's relatively new. I mean, the realistic evaluation, 1997, 28 years now, 30 years in 2027. It's as an approach, there's still so much room for development. What do you see based on the work that you've done already and your interest in the approach as the most promising direction for realist research in tackling medication safety and optimization in older populations?
I mean, I think you're right. It is a new approach, and it's only really the NIHR have probably only really picked up in the last 10 years. Although it's been out longer than that, it's only really the last 10 years that it's come up. I think what the exciting areas for realist research going forward. I mean, I think you mentioned it earlier, looking at how we can include health economics in it. I think that's really interesting approach to do. I know there's a lot of good work at Northumberland and other places looking at this. And I think that's really critical because policymakers, they want to know about the health economics. They want to know about the cash. So unless we can try to model that into it, I think that's that will have much more policy impact if we can include health economics. I think also the other interesting approach is including it in a process evaluation of complex interventions. I think that's an interesting approach. I would argue that people tend to see a drug trial for a drug that's been licensed as a simple intervention, taking a drug. I would argue it's often a complex intervention. And I think we could do quite a lot. We could explore it anyway, including these process evaluations with a realist lens within drug trials. To give you a good example, um, these drugs for dementia, which are given by infusion, they've been licensed, but NICE haven't approved them. But they're a complex intervention because you have to involve, person has to go to a hospital to receive the infusion or some sort of controlled environment. So we could do a realist evaluation to look at how we can understand the process for how we can actually ensure the patient receives the drug safely. I think that's an interesting area to explore. Obviously, I've given you exploratory ideas. They may not work, they may work, okay? But these also to build the number of realist researchers. There's not many, to be fair. Um, and also to try to get people to understand. I think healthcare tends to have the policymakers have a very quantitative approach, and I think to try to keep banging on. We need mixed methods when we're making policy decisions. Okay, we need to understand what's happening and why. And it's to keep going on to these policymakers. We need this rich data when we're doing policy, not just does the drug work. We need to understand the drug works, but people aren't taking it. People aren't taking the medication. We need to understand why. And you won't get that from numbers. You'll get that from approaches like realism. And realism's very powerful for that.
I
It's
love that.
prob-
Yeah, no, that's brilliant, Ian. Thank you so much. I think that what you mentioned there at the end is so important that it is, and it is, particularly if we look at the UK, it is true that NIHR and Realist it is growing and it is becoming funded, but actually when it comes to the final piece, and there's a really interesting chapter in Paulson's last book, How to Think Like a Realist, which is exactly about drug and medication development or trials that all the steps before the clinical trial and the RCT about efficacy, effectiveness, etc., they all have essentially a realist lens to it, understanding the mechanisms behind how it works and then testing its safety, etc. It's all realist, so to speak. And then it comes to the very end, which is the thing that's going to get funded or not, and it's a efficacy trial. So then it becomes like, what is it about policymakers or decision makers that's still very much into this positivist, i.e., objectivity, see if it works or not kind of thinking. And I think that they both can live in harmony. And as you mentioned, understanding that they're both needed for research. It's true that, realist is not a panacea. Positivist is certainly not a panacea. And no approaches is how we're working together as a research community to help answer these complex questions. And the capacity building that you mentioned, I think it's really important. And I think it's growing in momentum with the Ramsey's list, popping up every few days with questions and with more training. But I do think that it's also important in other countries. So it is in the English speaking world, it is becoming huge, but it's also to really become a realist community to get it into other areas as well. But that's a topic for another for another podcast.
No, I agree that it needs to be international. I mean, I think it is. I mean, it's centered on the English speaking communities, and I think it's got a lot of application more worldwide. The tension's always going to be funding. That's always going to be the tension, really. I think we do need to grow um, the, the the future realist researchers definitely. I agree with you. We need a combination of a positive approach and a realist approach because obviously we need to understand, does the drug work? I mean, you're not going to take a drug unless you know by numbers it's going to work. So you need that, but then it needs to be looked in combination with this understanding what's really happening.
Completely. I mean, it's something that as I mentioned, they both are going to be tools that helps us to answer different questions. So they should be living in harmony. Ian, I've loved our conversation. So many useful tips, useful thoughts, useful experiences of realists and your practice. And I mean, throughout the conversation, you've already given some top tips, such as like the stakeholders engaging in social work. But I'm going to test you a little bit further now because every conversation we always end with your top 3 tips. And if you have individuals listening to this podcast who may be realist researchers, pharmacists, PhD students who want to go into the topic of medication management in dementia care for older people or severe mental illness to do realist work, what would be your top three tips, the top three takeaways? A little bit like you've done with memorable in one phrase. What are the three phrases for us?
Okay, so don't be afraid to go for it. Don't be afraid to use a realist approach. Okay. I mean, I had when I did Memorable, I had no experience of realism. I just read a few books and we still got it funded. And I think we did a good job. Obviously, I'm about to say that. But so don't be afraid of the approach, okay? Go for it. Um, I think stakeholder engagement is critical. So I think having experts, practitioners for a PhD, obviously ideally the supervisors, need to have some content expertise. And I did have a third one, which had slipped out of my head when I was speaking to you. And it probably come back to me as soon as this interview's finished. So let me just did you speak and give me a second?
Absolutely, I can. But as you go for it, I really want to emphasize that go for it because I know that when you read a few of the realist textbooks or books, or it can seem very theoretical, jargon heavy, complex, etc., which actually sometimes probably been overcomplicated. But the actual essence of realist approach, we're all realists in our day to day life. We're always asking, how did that happen? Why did that happen? What is it about this? Things don't work for everyone. We're constantly thinking like that. So if you can translate that into a project, I think that it can absolutely, by the end of it and by the end of the tunnel, you can get a really rich and in-depth understanding. And I think you feel quite satisfied.
Yeah, no, I agree. My third point was actually when you were speaking, I reminded of it. Don't overcomplicate it. Don't make it too complex. Okay, you're right, but we do it all the time. We think why? What's really going on here? So just almost come back to kind of basics, almost in a way. Don't overcomplicate it. Don't make it too complex, which is essentially what you just said.
Number one, Ian, go for it and give it a go. Number two, stakeholder engagement. And number three, don't overcomplicate it. Think like a realist. Ian, absolutely loved our conversation. Thank you so much for your time, for your thoughts, for your ideas. And I'm sure people will find it very useful. And for anyone listening, thank you so much for another episode of The Realist Lens. And I'll see you soon. Ian, thank you so much.